Alrighty, hello everybody. So this is going to be part 2 of the Pharm review. We're going to go over our cardiac meds and our RAS system drugs and diuretics. So without further ado, we're going to get started. Alrighty. So remember about all your test preparations that we had to and we explained earlier. So we're going to start off on question 21. We're going to talk about digoxin and furosemide. So, furosemide is a loop diuretic, which loop diuretics cause excretion of both sodium and potassium from the body. A patient that is taking digoxin, which is a heart medication for heart failure, is at risk of having a life-threatening arrhythmia due to low potassium levels because furosemide makes you lose potassium, meaning you're going to have hypokalemia, or no potassium in your body, when you take furosemide. And if you take digoxin at the same time, it's going to be an additive effect. Patients are at risk for having life-threatening arrhythmias due to those low potassium levels. Nausea and vomiting can also play in a role of having that hypokalemia occur. Because of the interaction, the patient should cease use of the furosemide, use a potassium-sparing diuretic, such as spironolactone in its place, that will hold on to potassium levels and keep that potassium in the body. We have to also monitor our digoxin levels. Remember, therapeutic digoxin level is 0.5 to 2.0. We need to make sure we monitor potassium levels. Remember, potassium is 3.5 to 5. Telemetry, to watch for our EKG changes, and advise the client to eat foods rich in potassium or to use a supplement to increase potassium in the body if needed. Now we're going to go ahead and distinguish our potassium wasting and potassium sparing diuretic use. Okay. So, first we're going to talk about potassium wasting diuretics. So our potassium wasting diuretics are going to be our loop or thiazide diuretics. So these drugs work to block absorption of sodium, potassium chloride, and water. And because of that, these are going to be excreted from the body. It's going to cause rapid diuresis or excretion of urine. These medications are going to be used to treat heart failure, hypertension, edema, renal disease, or liver failure. So some of our adverse effects of these medications are going to be hypotension, low blood pressure because there's not enough fluid in the body, dehydration because we're ridding fluid of the body, hyponatremia because we're ridding sodium of the body, hypokalemia is because we're ridding potassium of the body, and hypochloremia because we're ridding chloride of the body. We may need to have potassium supplements to help maintain those normal potassium levels because we're getting rid of potassium in the body. So because of that, we can have low potassium, meaning we can have EKG changes. So we may need to prescribe a potassium supplement to increase those K levels and advise the patient that they need to increase their potassium-rich foods. Now we need to know about our K-sparing diuretics. So that medication is going to be medications like spironolactone. So spironolactone helps to block absorption of sodium and water, causing the body to hold on to potassium. It makes sodium and water become excreted from the body and holds on to potassium. So it's used for the same reason hypertension and heart failure. Some of our adverse effects are going to be hypotension, hyperkalemia, because the patient's holding on to more potassium, drowsiness, metabolic acidosis because of the high potassium, and gynecomastia, breast tenderness, irregular menstrual cycle, and impotence. Of course, we need to make sure that we monitor EKG levels to assess for any arrhythmia-related changes to the high potassium levels. Remember, we cannot give the patient salt substitutes that are using a K-sparing diuretic because salt substitutes have in them potassium, and that can add to higher potassium levels in the body. Concurrent use of furosemide and gentamicin. So furosemide is a diuretic that is ototoxic, so meaning it can cause toxicity of the ear. Gentamicin is an antibiotic that's also ototoxic, so we must advise the patient to not take these medications together. We have to advise to have caution. We must teach that patient to recognize the signs and symptoms of the ototoxicity, like tinnitus, and report it if they're taking these two medications together. Now we're going to move on to our RAS system drugs. So the RAS system is activated when somebody has a low blood pressure, and it helps to increase that blood pressure. However, a lot of these medications block at certain places in the RAS system, causing the patient's blood pressure to be lowered and to have vasodilation in the system. So, the first thing we're going to talk about is angioedema. So, angioedema is a life-threatening adverse effect of ACE and angiotensin II receptor blocker use. So, the signs and symptoms of angioedema are going to be that facial and tongue swelling, and it can be fatal if it's not treated. Initially, if you see somebody having that angioedema, you can treat with epinephrine, but we need to make sure that the patient who has angioedema must discontinue ACE inhibitor or angio2 receptor blocker drugs and never use them again, because we don't want them to have that angioedema occur again. So we'll put them on a different medication to control their hypertension if they have this effect. ACE inhibitors and coughing. So a prominent side effect with ACE inhibitors includes a dry cough. This is due to bradykinin being at increased levels in the lungs. If the patient does not like the coughing, we must notify the healthcare provider and switch the patient to another medication. We may give the patient, if they say that they have the dry cough, we may want to give them that, maybe a cough drop or dry candy. However, if they do not like the coughing after a while and it becomes annoying to them, we need to switch them to another med. Speaking of ACE inhibitors and their coughing, we need to know about their side effects and patient education. So a side effect of ACE inhibitors is first dose hypotension. That was not a dry cough. Dry cough is a side effect of ACE inhibitors. Angioedema, that face swelling. Hyperkalemia or high potassium levels, and fetal injury. So some education points we need to talk to our patients about when using ACE inhibitor is to change position slowly due to first dose hypotension. We don't want that patient passing out on us or falling. Those relief methods that I taught earlier. Remember that sucking on hard candy or cough drops. But if they can't handle that medication because of the cough, they must notify the provider to switch that medication. We need to teach about the signs and symptoms of angioedema and what to report to the provider. The patient will not take ACE drugs again if they have the angioedema. We need to educate the patient to avoid foods high in potassium and to avoid salt substitutes as they are full of potassium. For fetal harm, we need to make sure that they notify the healthcare provider if they're pregnant or if they plan to be pregnant while on the medication, because we don't want any fetal harm to the child. Remember, they will interact with case-sparing diuretics and cause even more increased levels of potassium, so we must educate the patient to not take spironolactone with ACE inhibitors. Now we're going to move on to some more of our medications regarding hypertension. These are not necessarily RAS system drugs. So first we're going to talk about nidedafine and metoprolol concurrent use. So nidedafine is a calcium channel blocker that works on the blood vessels only, which causes their dilation. However, a response that occurs because of nifedipine use is reflex tachycardia. And reflex tachycardia may cause more pain in those with angina. Because of this, we may use a beta blocker like metoprolol to prevent this reflex tachycardia. Now, since we've mentioned both beta blockers and calcium channel blockers, we're going to go into a little bit more detail about them. So beta blockers work to bind to beta 1 and beta 2 receptors and block their responses. Because of that block, it will cause decreased heart rate, decreased contractility, decreased cardiac output, decreased SA to AV node conduction. It will also decrease peripheral resistance and decrease renin release. We use beta blockers with those who have hypertension, angina, paroxysmal supraventricular tachycardia, or PSVT. It's a arrhythmia, heart failure, cardioprotection, migraines, and anxiety. Many different uses for this. Some side effects we must be aware of is a low heart rate because it causes decreased heart rate. So if their heart rate's below 60, we need to be aware of that. AV blocks slow conduction, bronchoconstriction and spasm, hypoglycemia, orthostatic hypotension, impotence, or depression. We do not want to use this with patients who have heart block or bradycardia, COPD, or asthma because of bronchoconstriction. Bradycardia, this medication is going to cause that heart rate to decrease as well. Remember, we can use this medication to prevent reflex tachycardia with nifedipine. Now we're going to move on to calcium channel blockers. So calcium channel blockers such as verapamil, diltiazem, and nifedipine work in two different ways. So one will work on the heart and blood vessels, vascular smooth muscle in the heart, which is your verapamil and diltiazem, or on the vessels only, which is going to be that nifedipine. They work to block calcium channels in smooth muscle, causing vasodilation, block calcium channels in the myocardium, decrease contraction and heart rate, and conduction, decrease afterload, and increases perfusion. It treats hypertension, angina, supraventricular tachycardia, atrial fibrillation, and atrial flutter. Some adverse effects of calcium channel blockers is that hypotension, reflex tachycardia, remember we can use metoprolol to help with that, dizziness, peripheral edema, and gingival hyperplasia. So before we give this medication, we must monitor the apical heart rate and the blood pressure. We have to take that apical heart rate for 1 minute. Remember, you're going to put it in that space there, and we're going to take it for 1 minute. And if the apical heart rate is higher than 100 and the systolic blood pressure is less than 90, we must check it. Don't worry about that. I'm going to repeat that sentence again because I got distracted and it scared me. So, with any calcium channel blocker, we have to monitor the blood pressure and heart rate and hold the medication if apical heart rate is higher than 100 and if the systolic blood pressure is less than 90. We must always change positions slowly with the medication, monitor weight, and give regular oral care due to that gingival hyperplasia. Remember, no grapefruit juice because this medication works on that CY34 gene thingy, and we must be careful with that. Treatment of hypertension in diabetics. So in patients who are diabetic and hypertensive, the target blood pressure is going to be in the same range as the population. Remember, less than 120/80. Some of our preferred drugs with patients who have hypertension and are diabetic are our ACE inhibitors, angio-2 receptor blockers, calcium channel blockers, and low-dose diuretics, like our diazides. Some of the medications may suppress that glycemic index and cause hypo or hypoglycemia. We should always use our diuretics with care with those who have diabetes, because it may cause that hyperglycemia, and we do not want that. Back to furosemide. So with furosemide, our indications again are going to be for heart failure, hypertension, pulmonary edema, adenoma states. We can have side effects of hypotension, dehydration, hyponatremia, hypokalemia, hypocalcemia, or chloremia, and hypomagnesemia. Remember, furosemide rids the body of all those chemicals and fluid. And it can be ototoxic. Remember, signs and symptoms of hearing loss, tinnitus, we need to make sure we report those. Hypokalemia may occur, and that can be very dangerous. We have to make sure we monitor that EKG and give K supplements and food within high potassium-rich food. Remember that furosemide interacts with digoxin, causing lower potassium levels, will cause lithium to increase. Antihypertensive will be additives and cause more hypotension because furosemide rids the body of fluid. Antihypertensives dilate the vessels, causing more hypotension. It can be additives, so we must be careful when using this and a antihypertensive medication. Back to digoxin. So we're going to talk about the therapeutic level is 0.5 to 2.0. You must know your therapeutic level on the test tomorrow. Because if it's not in the therapeutic level, we will not give it. We need to also monitor potassium level, 3.5 to 5. Digoxin can cause arrhythmias if used with the medications that rid potassium. Again, we mentioned that earlier. Remember, no furosemide with digoxin. If one has low potassium levels, arrhythmia can occur, which can be very dangerous and life-threatening. Before we're going to give digoxin, we need to assess our vitals first in potassium levels. Obtain that apical heart rate for 60 seconds, and we will hold the drug if the heart rate is less than 60 and the blood pressure is less than 90/60. Now we're going to talk about something very significant, which is digoxin toxicity. So this is when that digoxin level is going to be above that 2.0 or that therapeutic range. So some signs and symptoms we must be aware of is that early and late stages. So early you're going to have those abdominal pain, GI effects, nausea, vomiting, diarrhea. They're not going to want to eat. While the later ones, we are going to have that low heart rate, visual changes. Remember the halos, green, yellow, blue vision, flickering lights. How we're going to treat that digoxin toxicity is we're going to give Digibine IV as an antidote. And we need to make sure that we monitor the lab values of serum digoxin since they will go down slowly over a course of days. Next we have amiodarone. So amiodarone is a potassium channel blocker used to reverse dysrhythmias, ventricular fibrillation, or unstable ventricular tachycardia. It works on the heart to reduce automaticity in the SA node, reduce contractility, reduce conduction velocity, widen the QRS complex, prolong the PR complex, and QT intervals. Some of our adverse effects of potassium channel blockers, such as amiodarone, is pulmonary toxicity, cardiotoxicity, teratogenesis, corneal deposits, and optic neuropathy. Remember, these drugs also interact with that CYP344 gene, so no grapefruit juice with these medications because it can increase the levels, causing more toxic effects. No cholestyramine because it can reduce drug levels. Remember that a key thing with any dysrhythmic drugs, such as beta blockers, calcium channel blockers, sodium channel blockers, and potassium channel blockers, these medications may treat one dysrhythmia, but may also cause another. Our goal with any of our antidysrhythmics is to put the patient back into healthy sinus rhythm. Alright, let me see. We're going to go on nitroglycerin in a minute. Before I stop this recording, I want to talk about nitroglycerin. So nitroglycerin is a very potent medication that we will use for angina. So one thing is we will administer nitroglycerin in a oral form as a large first pass effect, and tolerance will develop quickly. What we will usually do when we give nitroglycerin is we're going to put it under the tongue, if oral, and let it dissolve. If the patient reports that they feel a burning sensation, that means the drug is working. If we use a nitroglycerin patch, we can remove it for 8 hours a day. Remember, with any patch removal, we must remove the old patch before placing a new one and rotate sites on the upper body with our patches. If we use a long-acting cream for nitroglycerin, we should always wear gloves when applying and remove all excess formula because nitroglycerin cream can go through the skin and cause toxic effects to ourselves as well. With nursing care of angina, this is such a very important topic. When we give a patient angina nitroglycerin, we will check vital signs before each dose if possible and give them 5 minutes apart. We will hold the drug if the heart rate is less than 60 or greater than 100, or the blood pressure is less than 100/60. If we are not in a hospital setting, we're going to tell the patient to stop activity, sit down and rest, take a sublingual tablet, and wait 5 minutes. If the patient says they still have angina, they will take a second tablet and call 911 and sit down and rest. If there's still no relief, take a third tablet and wait for emergency medical services. We want to tell the patient to never try and drive themselves to the hospital or have their family take you. They must wait for the EMS to come and evaluate them. Storage considerations for nitroglycerin include: we must put the nitroglycerin tablets in an airtight, dark glass bottle in a cool, dark place. Potency of the drug will be lost in 6 months after opening. Okay. Now, since we know very important considerations for nitroglycerin, we need to know how it works. So nitroglycerin is a nitrate that works to treat stable invariant angina. It can be used short and long term. This is not for unstable angina. Our mechanism of action is that it will be a vasodilator, act directly on smooth muscle to promote vasodilation. It lowers oxygen demand. An adverse effect of nitroglycerin is that it will cause headache, orthostatic hypotension, and reflex tachycardia. One thing we must ask our patients using nitroglycerin before we give it is if they take any medications that interact with PDE5, such as Viagra, because these drugs are not only used for erectile dysfunction, but they can have cardiac drug effects when used with nitroglycerin. We must ask our males with chest pain if they use PDE5 drugs. If they report they do use the drugs, we will hold the nitroglycerin. If we were to give nitroglycerin with these patients, then hypotension may occur, and we do not want that. All right. So that's going to be the end of part 2 of the pharmacology recording on a lot of our cardiac meds. On our next recording, we're going to go over our cholesterol lowering meds and our blood and anticoagulant medications.